So this session will be regarding SG dilators. So basically we have three sessions regarding dilators, endoscopic dilators. One is the SG dilator, second is balloon dilators, third is a comparison between SG dilator and balloon dilator. This session will be regarding SG dilator. The slides are prepared by Dr. Manoj and it has been modified by myself, and I have been narrating the slides in detail for you. Just an introduction regarding esophageal strictures. It can be divided as simple and complex. The simple strictures will be less than 2 centimeters, symmetric, and it will be straight. And it will be short and traversible. That means the scope can go inside, or even at least pediatric scope will go inside. While the complex strictures will be tortuous, and it can be associated with fistulas or diverticulitis or pseudo-diverticulitis. And risk of recurrence of simple strictures are less when compared to complex strictures, even after dilating. And etiology for simple strictures will be peptic ulcer strictures in the distal esophagus, pill drugs-induced strictures, scarring, anastomotic site simple strictures. While complex strictures will be malignancies, especially like we have the squamous cell carcinoma related strictures of the upper esophagus, or adenocarcinoma related strictures, post radiotherapy strictures, caustic injection related strictures. Rule of three. This is applicable before Bougie dilatation or balloon dilatation. It just means that maximum three sequential dilator size in incremental order, that is 1 mm each increment, can only be used per session. This avoids the risk of perforation. What does it mean is that if we are using an SG dilator from we started incrementally, and at 9 mm or at 10 mm we are having resistance free, freely the SG dilator is going inside, we can incrementally increase it only up to from 10 mm if it is free, 11 mm, 12.8 mm, and 13 mm. Only three extra incremental rise can be used. If we use 14 mm or 15 mm, the chance for perforation will be larger, higher. But this is not a validated rule. But in practice, we may use it, but it is not validated. So what are the contraindications of dilatation? Active ulcer is a contraindication. Perforation can happen even if it is ileal or colonic or esophageal. Presence of esophageal varices, we should not dilate. It will result in torrential bleeding. Severe esophagitis, LA grade COT, do not dilate. If it is a case of malignant strictures, be careful about dilatation. If there is a friable tumor, ulcerated tumor, or a squamous cell carcinoma is there, do not dilate. Do not be very much hyperactive to dilate to relieve his symptoms. Your dilatation in a malignancy case is only for the purpose of obtaining a biopsy. Do not dilate it too much also if you are doing it for the biopsy purpose. For dysphagia purpose, dilatation is not the choice in malignant strictures. Malignant stitches should be managed either surgically or by putting stems if it is inoperable cases. Perforation risk is very high. Esophageal esophagitis, if it is untreated, that means if steroids are not given, if they are actively inflamed, dilatation should not be attempted. First of all, give them steroids, reduce the inflammation. Only after that, if it is a fibrotic stricture only, dilatation should be attempted. If you have taken a biopsy from the site of a lesion, dilatation should not be done because perforation can happen, and the biopsy site can act as a lead point for perforation. There are some contradictory studies also for this, but in general, remember, if biopsy is taken, dilatation should be done carefully. Recent surgery, or if it is a fresh anastomotic site, don't dilate. Perforation or giveaway can happen. Presence of coagulopathy and the patient is uncooperative, do not dilate because it can result in perforation. Then recent myocardial infarction, esophageal dilatation should be avoided as it can increase the stress for heart, and mediastinitis if it goes triggered, and heart can go into tachycardia and cardiac failure can happen. Then tortuous strictures, dilatation will not be a choice. They may end up in surgical interventions. So regarding the dilatation, we have two type of dilators as discussed previously. One is Bougie dilator, second is balloon dilator. Regarding Bougie dilators, there are two types of Bougie dilators. One is non-wire guided Bougie dilators and second is wire guided Bougie dilators. Commonly, most of us would have used and seen the wire guided Bougie dilators. The non-wire guided Bougie dilators are not commonly used, But for the purpose of exam, we should understand there are two types of non-wire guided Bougie dilators. They are Maloney, second is Hertz. Basically, these are the non-wire guided Bougie dilators. They are inserted into the patient's esophagus, not wire guided, but we ask them to swallow the patient is asked to swallow the dilators. And these dilators are made stiff by filling it with some liquid metals. The Maloney dilator, like M4M, that is, the Maloney dilators are filled with mercury and that remains solid, and the patient is asked to swallow it down. While Hertz dilator is filled with tungsten metal and he is asked to swallow it down. But it is very difficult to do. Patient cooperation is very much important. It is done only for simple esophageal strictures, like a case of a small Satskin's ring or a small peptic ulcer stricture. While patient's cooperation is more required, and we usually don't use this non-wire guided dilators. So wire guided Bougie dilators are two. What we all know is a SG dilator, but we all forget one name, that is American polyvinyl esophageal dilator. Only the material changes, it looks white, and we do not commonly use in our countries. What we commonly use is the Savary Gillard dilator. It is from the Cook Scientific, and it is also made of polyvinyl. Regarding the size, we should remember there are size ranging from 5 mm till 20 mm diameter. So the 5 mm is a maximum dia and dia of the single dilator. It can range up to 20 mm dia. One important thing is that there is no 13 mm. 13 mm size is not there in the serial dilatation. Only 12.8 mm is there. So we have ranging from 5 mm till 20 mm. There are total 16 sizes are there in the full pack. 13 is not there. 13 mm is not there. And it is a semi-rigid made of polyvinyl, fixed diameter. We call it as push type. We have to push it down, and the length ranges from 70 centimeter to 100 centimeter, 100 centimeter for the 20 mm one. And at the site of maximal diameter, there is a radio opaque mark will be there. And dilator, if you, it should be kept kink free, otherwise the end will go and cause perforation. How do we do it? The procedure, very important thing. First of all, we should do an endoscopy and see where the stricture site is, and we should pass a guide wire beyond the stricture site. The neck position, the neck should be hyperextended position. That is also known as sword swallowing position. After removing the endoscope, the guide wire should be along the guide wire. The dilator should be railroaded down, and most importantly, the guide wire should be in a minimal traction and it should not coil. If it coil, what happens is that the tip of the dilator will go and pierce in against the esophageal lumen and can cause perforation. And here also rule of 3 should be used. We should insert the dilator along the guide wire, and pushing should be ideally done with the non-dominant hand so that excessive push will not happen and perforation will not happen. And caution should be made that your assistant maintains the guide wire in a minimal traction, and there should not be slacking of the or looping of the guide wire should not be there. Rule of 3 should be followed. That means at a point where you feel there is no resistance, that is, for example, if it is 11 mm, 3 serial dilatation can be done. We can insert 11 mm. After 11 mm, you can insert 12 mm, 12.8 mm, and 14 mm. After that, you should stop. If you feel a total giveaway feel is there, that means it is a perforation. Most patients will require repeated session after 3 weeks time. And SG dilator produces both shear as well as radial stress. This is very important point because the balloon dilators causes only radial forces. Shear stress is highest with Maloney followed by SG dilators. Maloney is the one which we learned as non-wire guided Bougie dilators. Success of symptom relief depends upon case to case, it may vary. For a case of esophageal stricture, only 75% success we may get, but esophageal web cases, 100% success we may get. And presence of small blood streak in the SG dilator indicates that we have successfully dilated. One important point, can biopsy and dilatation be simultaneously? Traditionally, we are taught that if biopsy is done, dilatation should not be done. But there are some controversial studies. Bakin et al. Had showed that there were no perforations following or complications following doing both simultaneously, but traditional teaching is no. Thank you. In next video, we will be discussing regarding balloon dilators, and after that, we will be discussing comparison of both. Please watch the next video also. Thank you.